Newer therapeutics is a very exciting topic, and I think this audience, it's a very relevant topic as well. So the general theme would be, when, as a physician, when would we consider the newer therapeutic agent? What does the current literature tell about the dose and administration? What is the mechanism of action of this newer therapeutic agent? From a practical perspective, what would be the pros and cons and the way forward? So I have divided the newer therapeutic agents into 4 groups. Group 1, drugs which are available, approved, and they are eligible to be used in children, but there is a physician inertia in using these agents. How do we tackle that? Number 2, drugs which are approved, used routinely in adults, anecdotal reports of their use in children. How do we tackle that? Number 3, drugs which are known to be efficacious in children in specific situations, but procurement of these drugs is a challenge. How do we tackle that? How do we use them? And drugs that may be available for use in the future. So what are the drugs? Number 1 would be aromatase inhibitors in short-statured children. So today morning we had a good lively debate on the use of these agents in constitutional delay of growth and puberty. But these drugs have been used for quite a long period in children with idiopathic short stature and children with growth hormone deficiency who are diagnosed late. So aromatase is an inhibitor that is located in the bone, that is located in the testis, that is also located in the brain. So you can be having these agents in the first, second, and third generation. And the commonly available literature as far as this particular drugs is are pertaining to the third generation drugs, that is the anastrozole and letrozole. So where, as a physician, can I consider use of these aromatase inhibitors? You can consider them in children with growth hormone deficiency who are coming in the verge of epiphyseal fusion. They present at 18 years with a bone age of, say, 15 years, etc. There should be a thought on use of these agents. Second is children with idiopathic short stature who present late, and the prediction equations are telling you that they are going to land up below the 3rd percentile. So these are 2 situations where a strong consideration could be given. The recommended dose in many of the studies would be anastrozole and letrozole in the doses that are depicted in this particular slide. And the mechanism of action, as all of us are aware of, is it inhibits the enzyme and prevents the conversion of the testosterone to estrogen and delays the epiphyseal fusion. So what are the pros of use of these drugs? I think the improvement in terms of final height in various meta-analysis is somewhere to the tune of about 2.5 to 4 centimeters with varied duration of treatment, somewhere between 2 to 4 years of treatment. I think this is something which we have to look into very carefully, because the prediction equations which have been done in those meta-analysis are based on varied techniques of skeletal maturity assessment and varied equations that have been used to calculate the predicted adult height. A couple of studies have included data pertaining to the final height, but they are in single digits. So I think, yes, there is a lot of emerging and a thrush towards the use of these agents. But the cons that we would have to remember is the impact of these agents on the vertebral morphology, the impact of these agents in the spermatogenesis, and the third would be very limited use of these agents in prepubertal children and girls. I think girls, again, there is a lot of recent data on use of these agents in adolescent girls, which is described as the Gale study. But still, they're all very small sample sizes. And the last thing that we have to remember is consider the use of aromatase inhibitors in children who present growth hormone deficiencies, who present late, and idiopathic short stature after taking a proper consent, and preferably an ethics committee approval. And we'll have to see how the data emerges. Probably it may be a promising thing in the future. Transdermal estrogen. I think this is something where we are really lacking. These are transdermal preparations of estrogen that are available in the market that can be procured. They are affordable, and this is how the literature describe how these transdermal patches should be cut to deliver the accurate doses. And there is plethora of literature available on how these agents should be used, and most of the data tells us that they are comparable in terms of efficacy, in terms of the induction of secondary sexual characteristics, growth of the internal pelvic organs, and in terms of better metabolic side effects. So indication for use of these agents would be in Turner syndrome, girls with hypogonadism, especially in the presence of metabolic complications like dyslipidemia, like early onset type 2 diabetes. This builds a strong case for use of transdermal preparation. You start with of these preparations in a dose of about 3 to 7 microgram per kg, and literature tells you how to cut these patches, and there is a lot of data to tell you the stability of the patches are maintained despite cutting as well. So, and you would also probably have to monitor the estrogen levels to ensure titration of these drugs. The estrogen is absorbed into the capillaries and delivered into the bloodstream. And the plasma estradiol levels are expected to remain stable. The advantage, the pros, the thrust for these agents comes with lesser cardiovascular risk, reduced risk of thrombosis, reduced metabolic complications, and you have robust levels that are available for titration and optimization of these doses so that you mimic physiology. And of course, the cons would be in a busy school-going adolescent, the practical aspects of application of these patches, the skin reactions that have been described in literature, and poor addition of these patches. So I think this is something which I think I would encourage the practitioners and all of us to use these in right settings and report them. Long-acting octreotide. I think Sir gave a very nice talk yesterday. I think if you look up literature from Indian setting itself, there is data pertaining to nearly 30 to 40 children who have been given long-acting octreotide from South India, from West India, and from North India. And there has been clear indication that it is efficacious, not only in diffuse, but also in some cases of focal. And there is a good group of children where the daily injections are stopped, and it is helpful not only in the diazoxide responsive group of children, even in the diazoxide unresponsive group of children. I think so there is a strong case for use of these agents at least above the age of 3 months. So once you tide over the newborn period with octreotide, there is a push for you, and of course improvement in quality of life. There are only anecdotal reports of not responding to this, going in for more advanced forms of therapy. So the indication would be children with PHHI requiring multiple octreotide injections to maintain sugar levels. You would have to calculate a monthly dose based on the daily dose and give a cumulative dose once in a month. And probably because the preparations are available in higher strength, they may have to be pulled together and administered. It suppresses endogenous insulin production, lesser pricks, as efficacious. The cons would be long-term safety, how follow-up period after use of these agents, what is the long-term results is not known. And of course, they need to have their growth and thyroid functions monitored, and liver function test, which was very beautifully highlighted in the previous case yesterday, has to be thought of. Lot of Indian data, as I said, is available. I think this builds a case for us to use them. The fourth drug I would say is sirolimus. There is, again, I have summed up the literature on the cases that have been used from our own country, somewhere to the tune of around 15 to 20 children. What is interesting is the drug is available, and there is an explosion in the use of this drug, not only in diffuse cases as per the original trial, but also in children with focal as well as residual disease after a surgery. So the dosing guidelines are available, and of course, it needs to be managed by a team with a good support from an ICU backup as well as a hematologist who can help you. The outcomes are varied. The dosings are different in different studies. I think you have to start on the lowest dose and slowly advance the doses. So children who are resistant to medicine and require high GIRs can probably be considered. You start off on a small dose, 0.5 mg per meter squared. You can go up to, literature says, 5 mg per meter squared. And of course, it is an mTOR inhibitors. It avoids the need for pancreatectomy. But the side effects have to be explained, and including the life-threatening risk of infections and the various systemic side effects. Always prefer to use it in a higher center with an ICU and a hematology backup. So now I come to the second group of drugs which are used in adults, emerging role in children. The first one is an extension of what was discussed today morning, recombinant parathyroid hormone for hypoparathyroidism. This is a very beautiful review where about 70 to 80 children have received parathyroid. So it's not that it's an experimental drug. From good centers, about 70 to 80 children have received parathyroid hormones, and follow-up of this is available till about 10 years. So it is indeed a safe drug, but the context of usage it has to be very clearly defined. So this is an Indian study who have used the use of described the use of parathormone in an acute care setting in the ICU, where they found the hypocalcemia to be really refractory. They proved the condition and they administered and they brought the child out of ICU. At least short-term data is available. So, etiologically confirmed cases of hypoparathyroidism with the development of renal complications or requirement of second-line drugs, phosphate binders or thiazides, there builds a strong case. The dosage would be 0.5 to 1 microgram. You can slowly advance it to around 5 to 10 microgram. It is a physiological replacement of the hormone. The benefits would be, as discussed, better renal function, better control, no need for second-line drugs, improved bone health, etc. But of course, a black box warning of osteosarcoma really tends to haunt us. Patient consent and appropriate monitoring would be the way forward. Monoclonal antibodies in genetic dyslipidemia. I think Dr. Hari gave a very nice emerging role of this novel therapeutic agent, especially in children with genetic dyslipidemias, where it's a losing battle in most of the situations. I think this is an Indian report of the use of this biological agent in a North Indian girl. And the authors have very beautifully from PGH Chandigarh, and where the authors have very beautifully described, you can see the decline in the LDL cholesterol after from the 3-digit numbers to 2-digit numbers. So I think it seems to be a wonder drug, at least in a short-term basis. And you can see beautifully the graphical representation of the decline in the lipid parameters after use of this biological agent. So I think this is a novel therapeutic agent that looks very promising. So not responding to conventional therapy. These are the dosing guidelines, subcutaneous and the intravenous dosing guidelines. It delays the clearance of the receptors and improves the receptor expression. About 80% reduction in LDL has been reported, and this author from PGA, who has, I think, sir student, who has reported it, and this seems to be a very promising drug. The side effects are very minor. The way forward would be taking a patient consent, ethical clearance, explaining the pros and cons, and of course, explaining the fact that we are in a desperate situation and something is better than nothing. And I think the short-term efficacy of this drug in anecdotal case reports is very promising. The third drug, I think this would be, I wouldn't really, this is a child with precocious puberty. Maximum doses of GnRH analog treatment have been given, but what next? So this is building a case for GnRH antagonist therapy, which is probably used in young ladies and women with endometriosis, which is available in market. And anecdotal reports of use of these agents as daily injections are available. So how frequently we encounter, maybe once a way. Maximum doses of GnRH analogs you have gone to for the age and weight, and still you're not able to control the disease in terms of the growth, the biochemical parameters, and the skeletal maturity. So you can start off with these are the dosing guidelines. You go on with weekly and then go in for bi-weekly. This I've just taken from the case report that has been. So the rationale is these agents act not only on the brain but also on the gonads. So dual hit kind of a theory and acute suppression of the hormonal disease. And the advantage is there is is no initial flare of this drug after initiation, which is usually encountered in GnRH analog treatment. Of course, more frequent injection, higher cost, and lack of data remains the challenge. You can consider it on an individual case based after probably a team discussion and taking the consent and ethical approval. And of course, this is the next promising drug, denosumab. Difficult OI. You have gone to the maximum permissible limit of bisphosphonate, zoledronic acid, and the fracture just doesn't seem to come down. I think there is a lot of studies. If I summed up the number of children, there are almost about 400 to 500 children who have been given this agent. But the dosing guidelines are very, very varied in terms of 1 mg per kg. In some studies, it's 60 mg extrapolated from adult. And they have given the rationality of description of these. So dosing is not very clear. They are monoclonal antibodies that target the rankle, and it is supposed to be efficacious and helpful in these children in terms of improvement in the bone mineral density, improvement in the fracture frequency. The big worry is rebound hypercalcemia. In fact, there is literature described of almost going to the range of hypercalcemic crisis warranting ICU care. So this is something which we have to keep in mind. But I think this is a promising drug in the days to come, denosumab, for refractory, difficult to treat OI. Probably in the days to come, we are going to see more children being treated with this. So coming to the third group of drugs that can be procured with efforts from out of country and used in the right situation. Burosumab. Burosumab, in genetically confirmed cases, it's a monoclonal antibody that directly addresses the pathology in terms of blocking the FGF23 activity. And it is known to improve the biochemical, clinical, and well-being of the child. So the consideration can be given in children who have a genetic confirmation beyond the age of 2 years with adverse reaction to conventional therapy. So that would be the case for giving this treatment. The dosing guidelines are 0.8 mg per kg, given as subcutaneous injection probably once in 2 to 4 weeks. It is a recombinant antibody that blocks the action of FGF23. The documented and well-established benefits include the increase in the serum phosphorus, improvement in the biochemical parameters, improvement in the radiological parameters, the improvement in terms of the side effects of the medication and quality of life. The cons would be unclear impact on the deformity, the primary deformity, what happens to that, long-term safety, and a very interesting condition of restless leg syndrome, which has been described in some children who have been treated with this. The way forward is probably making the drug available, more prospective studies after making it available in our country, and consider early burosumab treatment and see how these children do would be the way forward as far as this drug is concerned. This is recombinant IGF-1 in children who have genetically confirmed Laron syndrome. The use of recombinant IGF. As far as Indian data is concerned, there is one case report from AIIMS who have described a growth velocity. They are desperate. They are extremely stunted. They have a therapeutic agent, but they're the practical difficulty in filling the fuel of the car. This is the report from AIIMS who have described about 6 centimeters with continuous treatment per year treated for growth hormone. Our own center, we have one child which we presented in the APIS meeting with a genetically confirmed Laron syndrome, IGF deficiency, and we found that the height Z-score improved from -7.9 to -7.2. So it's probably marginal, but for that it is like seeing an oasis in a desert in terms of the growth. So it's a desperate. I would really like to highlight that a genetic confirmation is necessary. And some practical experience, hypoglycemia is a big problem. CGM has been reported to be helpful, which was helpful in our case as well. Insulin syringes, 100 IU syringes were used to administer drug in appropriate doses. There is a very beautiful BSPED guideline which describes how it should be used. And this is a prohibitive cost. When the child was started on a low dose, the cost was around 55,000 per month. And now it is escalated to nearly 1.5 lakh lakhs per month, which they are paying from the pocket, and it really builds a case for advocacy. So recombinant IGF-1, genetic testing is preferable, 80 to 120 microgram twice a day per dose. It improves the oxology, improves the final stature. Hypoglycemia, tonsillar enlargement, and raised ICT should be looked into. Hypophosphatasia is another important condition, genetically confirmed disease with low alkaline phosphatase. You have to always compare it with the norms, and probably you should also keep in mind a genetic confirmation is necessary. There are specific designed criteria on replacement of alkaline phosphatase in children with a genetic confirmation. So these are the guidelines. So with a genetic confirmation, you start off with this agent 2 mg per kg on alternate days and slowly escalate it. And the benefits cannot be overemphasized. Reduce pain, disability, increase in the ALP, reduction in the fracture, improvement in the growth, etc. The development of antibodies, local reactions, and vascular calcification is a con. I think the way forward would be the prohibitive cost, the import taxes, and reaching it to the right patient. An Indian case report from one center in South India in Mysore authors have given a dose of have started the treatment of recombinant ALP in a child, and they have reported it in IJEM. And what they have observed is there's a good improvement in growth, radiological parameters, the motor milestones, and the developmental milestones. So I think this is a promising treatment, a novel therapeutic agent, which can be procured and offered in our setting. Vosoritide, I think there is a lot of data coming up in terms of use of this agent in children who have a genetic confirmation of achondroplasia above the age of 2 years with a genetically confirmed disease. 15 mg per kg subcutaneous injection. It restores chondrogenesis, acts on the NPRB, resulting in down regulation of the signaling pathways. The benefit would be 1 to 2 centimeters addition per year of treatment given. So on a long-term basis, again, the quantum of response may not match the efforts and cost, but at least it's an oasis in a desert in terms of these children who are so desperate for improvement in stature. I think this is a very promising drug, and the availability of data. And of course, the worry would be the side effects in terms of obstructive sleep apnea and tonsillar enlargement. Teplizumab, another promising agent, which is approved, as all of us are aware, in children with type 1 diabetes in a pre-symptomatic phase with 2 positive antibody reports aged above 8 years. The drug can be procured as an imported drug from outside and probably given after ethics approval and patient consent. It is given as infusion over a period of 14 days in small escalated divided doses. The dosing guidelines are available. You start off with the cumulative doses 9 mg per meter squared. And what the data tells us is the onset of type 1 diabetes is delayed. So I think this is a very, very important, promising drug, novel therapeutic agent, which really can make a big difference in their future. The last group of drug is pertaining to children with congenital adrenal hyperplasia. We have a lot of work that is going on in terms of acting CRH receptor antagonists who work on the pituitary and bring down the ACTH pulses. Modified release hydrocortisone, Chronocort and Plenodron, which kind of sustain and reduce the dosing frequency and help to mimic physiology. Granular forms of hydrocortisone, which help to give infants with smaller doses, and adrenal biosynthesis inhibitors in children who have very high androgen level despite having good. This is a sum up slide describing the pros, cons, and dosing guidelines for all these agents, which is there in a lot of published articles. The con is the use of these agents in sick days is a big question. The long-term safety, availability. These are the 3 problems as far as the novel therapeutic agents are concerned. Probably in the days to come, we are going to have it more helpful in our children with CAH. So, of course, I think to sum up, the Indian Society of Pediatric Endocrinology has taken a lot of effort. I think in terms of setting up of advocacy groups, and this would be the way forward in terms of the prohibitive cost. It's like you have a battery of therapeutic agents, and you have a whole lot of children who really would be benefited. I think connecting the two in fighting the prohibitive cost in terms of inclusion of these diseases in the rare diseases group, or finding some ways, reduction in the import taxes. I think the problem comes with when you procure these drugs, the parents tend to pay a whopping amount in terms of the taxes. So probably as a society, when you write to them and you try to get the import taxes waived off, regulatory clearance, right, writing from the society to the DGCI to include these drugs in their list, so that the regulatory hassles which clinicians when they use them go through can be subdued, and limited Indian data, and probably help in ethical clearance of use of these drugs. So advocacy is the way forward. I sum up with the 5 R's: a right indication, a responsible physician, a rational use, regulatory clearance, and reporting them in literature is probably the way forward to reach these children to the right children.